Well, hey everybody, this is Robert and welcome to Outbreak News TV. And today I want to look at a pretty interesting paper that was published in Emerging Infectious Diseases this week concerning an individual that acquired dengue virus in the laboratory. And it's a very interesting case, and I want to share that with you in a second. But in case you're not really well aware of dengue fever, I thought I was going to go over some of the basics so you can go into this with a basic knowledge of the virus and the way it's transmitted. So dengue viruses are spread to people through the bite of the infected Aedes species mosquito. That includes Aedes aegypti and Aedes albopictus. It is very common and it's present in more than 100 countries around the world. 40% of the world's population, or about 3 billion people, live in areas with a risk for dengue. Dengue is often a leading cause of illness in areas with risk. So let's look at the transmission. Typically through mosquito bites, as I mentioned. It can also be transmitted from mother to child. A pregnant woman already infected with dengue can pass the virus to her fetus during pregnancy or around the time of birth. To date, there has been one documented report of dengue spread through breast milk. Because of the benefits of breastfeeding, the CDC says mothers are encouraged to breastfeed even in areas with risk of dengue. Let me go back to the mosquito real quick. The types of mosquitoes that transmit dengue are the Aedes species, right? Aedes aegypti, Aedes albopictus, the same mosquito that transmits Zika and chikungunya, yellow fever. These mosquitoes typically lay eggs near standing water in containers that hold water, like buckets and bowls and animal dishes and flower pots, etc. They prefer to bite people and live both indoors and outdoors near people. They spread the viruses via a bite during the day or night, and the mosquitoes become infected when they bite a person infected with the virus. And then the infected mosquitoes can spread the virus to other people through bites. And then the last part, and this is going to be our topic for today, is it also can rarely be transmitted through blood or a laboratory accident or some other kind of healthcare setting exposure. So dengue has been spread through blood transfusion, organ transplants, or through a needle stick injury. But like I said, pretty rare stuff. Symptoms: about 1 in 4 people infected with dengue will get sick. Most people who get sick, the symptoms can be mild. And sometimes they can be severe, and the severe infections can be life-threatening. That could require hospitalization, and as I said, it could lead to death pretty rapidly in certain cases. Mild symptoms can be confused with a whole bunch of other illnesses, very nonspecific symptoms, fever and body aches, a rash. The most common symptom of dengue is fever with any of the following: nausea, vomiting, rash, aches and pains around the eyes, muscles, joints, bones. Symptoms of dengue typically last about 2 days up to a week, and most people will recover during about a week's period. There's no specific treatment for it. Basically, you treat for the symptoms. And I wanted to show you areas of risk for dengue. Dengue around the world. So you can see it's the darker the color, the more frequent or continuous the dengue risk. So, right, most of Southeast Asia, South Asia, parts of Eastern Africa, Yemen, right, parts of the Middle East, large swaths of South America and parts of Central America, and parts of the Caribbean. So yeah, so it's pretty common. There is some sporadic risk in some other countries, other parts of Africa, Florida. You see that once in a while. Some parts of Australia, some sporadic risk. And yeah, I think that's a good primer before we get into the paper. So let's go ahead and take a look at that. And this was published very recently, July 26th, in the journal Emerging Infectious Diseases. And let's start out with this. In August 2018, the North Carolina Department of Health and Human Services was notified of a dengue case in a laboratory worker. The health department and the CDC conducted an investigation to identify the most likely route of transmission. It says, we interviewed the case patient and reviewed medical records to collect travel history, potential exposures, clinical course, and diagnostic test results. The case patient reported no recent travel to an area with ongoing dengue virus transmission. No travel-associated dengue cases were reported in 2018 from the county where the case patient worked and resided. The case patient reported illness onset on July 18, 2018, with retroorbital eye pain, fever, myalgia, arthralgia, lethargy, chills, swollen lymph nodes. By July 23rd, the patient was afebrile but had a whole body maculopapular rash. The case patient was evaluated by a physician that day and received the diagnosis of viral illness. After reporting the illness to an institutional occupational health clinic, the case patient was referred to an infectious disease physician. And what we saw was they had 4 serum samples referred to the CDC. Baseline specimen collected about 1.5 years prior to the illness onset. There was an acute specimen collected 7 days after illness onset. An early convalescent specimen collected about a month after illness onset, and a late convalescent specimen collected about 6 months after the illness. The acute specimen tested positive at a commercial laboratory for non-structural protein 1 antigen and the dengue virus IgM antibody. Reverse transcription PCR performed on the acute specimen was negative. Dengue virus IgM and IgG were detected in acute and convalescent specimens. In the baseline specimen, neutralizing antibodies were detected for yellow fever virus, but not dengue virus or West Nile virus. Comparison of dengue virus neutralizing antibody titers in acute, early convalescent, and late convalescent serum samples confirmed incident dengue virus infection. However, a greater than or equal to 4-fold rise in neutralizing antibody titer against multiple dengue viruses precluded identification of a specific infecting dengue virus. Okay, so they went to the research laboratory where the case patient worked and learned about the different laboratory safety protocols. They reviewed laboratory activities by the case patient during the week before the illness and interviewed the case patient regarding practices of donning and doffing personal protective equipment. How do you put it on? How do you take it off? Now, in the 2 weeks before illness onset, the case patient reported working with a protocol to grow, purify, and concentrate dengue virus type 4. The case patient reported wearing a single pair of nitrile gloves, eye protection, a lab coat, and closed-toed shoes while working with infectious virus in a certified biosafety cabinet. Now, the protocol for the virus production and concentration included inoculating around 40 roller bottles of virocells with 10 to the 6 plaque-forming units of dengue virus 4. The media were harvested and pooled on day 5, 7, and 9 post-inoculation and concentrated by tangential flow filtration, followed by sucrose gradient fractionation. Fractions were collected by piercing the centrifugation tubes and collecting fractions using a safety mechanism that prevented needle sticks. The case patient also performed neutralization and ELISA assays for dengue viruses 1 through 4 during the 2 weeks before illness onset. Now, the patient reported that small splashes often occurred during virus production and purification. The case patient did not change gloves when splashes occurred, but occasionally performed surface decontamination of the gloves and the BSC with 70% ethanol. The patient estimated entering and exiting the BSC 6 to 8 times per day on most days of the protocol, but not being vigilant about hand washing after removing gloves. The case patient reported taking online biosafety level 2 training upon joining the laboratory, receiving hands-on training for BSL-2 work, and annually reviewing laboratory safety plans and procedures. And this is where it gets interesting. Now, the case patient reported having sustained a compression wound on the ring finger of her left hand on July 9 or 10. The wound later appeared infected and oozing. The case patient reported not bandaging or covering this wound before donning a single pair of gloves while working on the protocol for virus production and purification. The case patient demonstrated their technique for doffing gloves, taking off the gloves. The base of the glove of the left hand was pinched with the thumb and the forefinger of the right hand, and the glove removed while turning it inside out, after which the base of the glove on the right hand was pinched with the thumb and the forefinger of the now ungloved left hand. The case patient acknowledged that the wound on the ring finger of the left hand could have contracted the potentially contaminated glove on the right hand. The case patient also mentioned having potentially touched mucosal surfaces of the nose or mouth with the lab coat sleeve while working with infectious virus in the BSC. And in this picture, they do a pretty good job of showing improper protocol for doffing gloves. And you can see how they're pinching the glove right there. But here, you have the X here in picture number B, letter B, where the bare ring finger was touching the outside of the glove. And here we have it again in picture C. And then again, another problem in picture D. So the red X indicates the location of the open wound on the ring finger of the case patient's left hand. So let me go ahead and just talk about the conclusion. A couple paragraphs is pretty interesting. They say the presence of an open finger wound during work with a high-titer dengue virus coupled with improper glove doffing suggests that the laboratory-acquired infection by cutaneous exposure was the most likely route of dengue virus infection in this case. However, other routes of exposure, including mucosal, could not be ruled out. There is some precedence here. 3 previous cases of laboratory-acquired dengue virus infection have been reported. In Nigeria, a laboratorian responsible for cleaning cages and disposing of mice infected with dengue virus 1 became infected, although mosquito-borne transmission could not be ruled out. A second one, a laboratorian in Australia, was infected while working with dengue virus 2, although it could not be determined if infection occurred from a bite from the infected mosquito in the laboratory or a potential mucocutaneous exposure while working with infectious virus. And thirdly, in South Korea, a laboratorian was infected with dengue virus 2 following a needle stick injury while filtering cell cultures of the virus. And let's see if there's anything else I wanted to touch on there. Now that's pretty much it. So I guess what it boils down to is this is really telling us that this investigation is telling us the importance of developing and maintaining risk assessment and management programs to mitigate exposures to infectious agents, and emphasizing good microbiological practices and procedures, training for laboratorians, including proper PPE, donning, and doffing techniques. So anyway, I thought that was a really interesting little study put out there in Emerging Infectious Diseases. And I hope you enjoyed it. I'll link to it below if you want to read it for yourself. It's pretty good stuff. And let me go ahead and close with this. Here on the YouTube page, Outbreak News TV, I've done different stories and different interviews about dengue fever, and I encourage you to check these out. They're all pretty good. The one on the top, of course, is Can Dengue virus be sexually transmitted? There was a suspected case of sexual transmission in Madrid about 7-8 months ago. I also reported on the incredible large amount of outbreaks in 2019. In the second video, the rise of in outbreaks this year is a wake-up call. And lastly, here at the bottom, which says Dengue 19, you can see that I did a interview with Cameron Rafiq. He's the co-founder of the International Society for Neglected Tropical Diseases, and we talked for about a half hour or so about the situation with dengue fever in 2019 and a look to this current year. This was done about 5-6 months ago, so it's a pretty good interview. I encourage you to check it out. And I'm going to go ahead and wrap it up there. I appreciate you watching. Please comment below. Let me know what you think. Subscribe to the channel, and most of all, share it with your friends. And I'll see you next time on Outbreak News TV. Thanks a lot.